Hello and welcome to MD Newsline. Thank you so much for being here with us. Please introduce yourself to our audience.
Well, thanks for having me. My name is Dr. Oluwakemi Onajin. I'm an assistant professor of dermatology at the University of Chicago. I'm a board certified dermatologist and dermatopathologist.
Great. So tell us a little bit about your specialties. What are your areas of focus?
Yeah, that's a great question. I focus more on inflammatory skin diseases or what we call complex medical dermatology. So I see patients who have autoimmune skin diseases like lupus, dermatomyositis, sarcoidosis, and I also specialize in hidradenitis suppurativa.
Yeah, which is what we want to talk about. We're going to say HS for short, right?
Yes, we can say HS.
So tell us a little bit about what HS is. What does it look like? And tell us about the pathogenesis. Like, how does it manifest?
Yeah, so HS is a complex disease. So it's an inflammatory disorder that involves the hair follicles in certain areas of the body. So primarily the intertriginous areas. So those are the body folds, like the underarms, the groin area under the breast, and the buttocks. And it's a debilitating chronic disorder. There's no cure for this disease.
So, how do most people come to realize that they have HS? What's usually the process from symptoms to diagnosis?
Yeah, and it's great that you asked that question because hidradenitis suppurativa is commonly misdiagnosed, and it takes a long time for patients to get diagnosed, on average 7 to 10 years. So patients will notice that they get these painful boils, is what they call them, in certain areas, like their underarms, like the groin area, and these are relapsing and chronic and occur multiple times a year, sometimes lasting for months. And they're very painful, often draining some fluid and blood and all of that. So,
So then, do patients usually think these are ingrown hairs? What do they usually come into their, let's say, primary care physician and discuss, and then what leads them maybe to an HS diagnosis?
most of the time, patients think it's an abscess or a cyst. And a lot of times, patients are actually going into acute care facilities for urgent care and emergency departments, and they're getting treatment to incise and drain. So that's to open up and drain these lesions. So most of the time, patients actually go to these acute facilities because of how acutely painful these lesions are.
So then they go to the acute facilities, but they're being treated as boils. When do they get an HS diagnosis?
It can take 7 to 10 years. And now that we're raising awareness that providers, physicians, clinicians at these acute care facilities now know that when patients come in and if they have typical lesions, so the diagnostic criteria for HS is having typical lesions like nodules, abscesses, or these tunnels or tracts under the skin and they occur in certain areas of the body, so intertriginous areas. And these lesions occur more than twice in a 6 month period. So, all of that is enough to diagnose HS.
Gotcha. So are there any outside of kind of a visual diagnosis? Are there any other tests that people use to diagnose HS?
HS is more of a clinical diagnosis. Now, there are some laboratory tests that can show the level of inflammation in the body or can show high inflammatory markers, but these are not specific to HS, but it's a more of a clinical diagnosis.
Gotcha. So how does things like follicular occlusion contribute to HS development?
Yeah, so that plays a major part in the pathogenesis. And actually, the pathogenesis of HS or the proposed pathogenesis of HS has changed over the last few decades. Initially, it was thought that HS was inflammation of the apocrine glands, which is the sweat glands in these intertriginous areas. And then it was thought that it started out as occlusion of the follicles. But now what we know is that there's actually underlying inflammation around the follicles and we think that there's certain factors that predispose patients to this inflammation around the hair follicles that then leads to follicular occlusion. And then what you get is a rupture of the follicle, the contents of the follicles leak out into the surrounding areas and further drive inflammation.
So, what are the factors that predispose people to kind of that rupture of the follicle?
Yeah, so certain factors include family history, genetics, environmental lifestyle factors like smoking, diet, and also certain um, hormonal factors. So HS is more common in women, and a lot of women will notice that once they hit puberty, that's when they start to get um, their symptoms. So those are the factors. Yeah.
So, when it comes to certain environmental factors, you mentioned like smoking and things like that. What do those do to the body? What do those factors do to the body that make HS more likely?
So, smoking specifically actually has been shown to raise inflammation or induce inflammation in the body. But not only that, smoking actually also induces follicular occlusion. So, it causes occlusion of the follicles that is also driving HS.
So, from a genetic standpoint, how is understanding that there may be genetic factors, how is that playing a role in getting people diagnosed or helping people understand that they have a predisposition? Are there markers that we've identified, or is this something that becomes a part of the conversation in dermatology or primary care?
Yeah, well, it's now becoming a major part of the conversation. We know that 40% of patients who have HS have a family history of HS. Studies have also shown that patients who have a family history of HS are more likely to have HS starting at an earlier age, so an earlier onset of HS, and are more likely to have severe disease. There have been some studies that have shown mutations in certain genes, but this makes a very small percentage of the HS population, so about 5%. So there's some studies showing mutations in the gamma secretase complex that is involved in Notch signaling. And then there are some genome wide association studies that have shown certain genetic mutations, but again, a very small percentage of the HS population.
And you mentioned that when people hit puberty, they find that that's when the HS surfaces. And I'm wondering that you mentioned this is also having some hormonal components. What hormones are involved? Because in my mind, I'm thinking about like hormonal acne. That
Oh,
women tend to have monthly. So, is there
yeah.
any relation between that? How do hormones
There
play?
is. There is a relation between that, and it's thought to be the same hormones. So, androgenic or hormones, or like testosterone, or androgenic hormones are involved, and also the fluctuations in the hormone levels. So, that's why patients, at certain points, puberty, onset of the menstrual cycle, usually a week before the menstrual cycle, that's when you start to get those hormonal fluctuations. And also during pregnancy, that's when we tend to see that patients are getting more flares around this period.
So, what's the typical treatment regimen for a person with HS, and are there different classifications for severity of the disease?
Yeah, so the earliest classification or staging system is called the Hurley staging system. And this is divided into three stages: stage one, which is mild disease, stage two, and stage three. Now, the issue with this classification is that it's very simple. It's overly simplified, and so patients with stage one have nodules and abscesses, no scarring or tunnels. Patients with stage two have nodules and abscesses with some scarring and maybe one or two widely spaced tunnels. And then patients with stage three disease have multiple interconnected tunnels and scarring. The problem with this staging system is that it's static, so it's not dynamic. It really doesn't tell us the activity of the disease, but it's helpful when we're trying to decide what treatment to start patients on. A more recent scoring system is the IHS4, the International Hidradenitis Suppurativa Severity Scoring System, that then allows for counting of lesions, and that tells us how severe the HS is. So if a patient has nodules, you multiply the number of nodules times one. If the patient has abscesses, you multiply that by two. And if the patient has draining tunnels, you multiply that by four. So if the patient has a total score of three or less, that's mild disease. Total score of 4 to 10 is moderate disease, and greater than 11 is severe disease. Now, the reason why I'm laying this foundation is because this tells us how to treat HS. So treatment is based on if it's mild, moderate, or severe. So for mild HS, we typically focus more on topical treatments, so topical antibiotics, topical agents like resorcinol. And then sometimes for flares, we would give antibiotics, systemic antibiotics. And then for moderate disease, we start to think of more like immunomodulators, like biologics, in addition to all the other treatments for mild disease. And then we also start looking at surgical options, so deroofing and wide local excision. And then for severe disease, we're looking at IV antibiotics, more extensive surgery, and even sometimes combining immunomodulators.
With the antibiotic treatments, does this change the frequency of occurrence of the ruptures and the nodules?
Well, so at least for me, when I treat with antibiotics, the goal is not to treat with antibiotics long term. Um, so if a patient is needing antibiotics more frequently for flares, then that tells me that their disease is not well controlled. There's a lot of inflammation that then we need to look at immunomodulators. So we we HS experts do not like to use antibiotics long term or during for multiple courses. Yeah.
And does that have to do with antibiotic resistance, or what is that related to?
Yeah, it does. It has to do with antibiotic stewardship is very important, and we understand this, and we also know that antibiotics really, after a while, honestly stop working when you use it long term. So we save those for short term treatments for flares.
And when should things like surgical intervention kind of come into the conversation? Because it seems really intense. What does that entail, and when does it become necessary?
I honestly think that surgery should be considered for most patients. Now, there are some patients who have very severe disease and have certain comorbidities that make them, poor candidates for surgery, and very extensive disease also. But mild to moderate disease, if a patient has, for instance, one particular lesion that keeps flaring on and off, but they don't have any other lesions, but just this one particular lesion, you can actually do a simple deroofing procedure, or what we call a punch excision, which means just taking out that lesion, leaving the area open and allowing it to heal on its own. And that is tremendously helpful for these patients because that was the only lesion that was giving them trouble. And then for moderate disease, I always tell patients it's important for us to control the inflammation first before we consider surgery because the driver of the disease is the underlying inflammation. If we rush to surgery too soon, there's complications from the surgery, there's poor wound healing, and there's a high risk of recurrence of the disease.
So when it comes to recurrence, is it typical that the same area has the flare up, or are there new nodules every time? Like if a follicle bursts, is it the same follicle every single time, and then the surgery kind of focused on that? Because you mentioned having just one lesion that keeps reoccurring. Is that typically how it works? Or
Yeah, so the surgery really only helps with local remission. So the surgery does not prevent the HS from appearing in other areas that were not treated with surgery. But then again, it's important to make sure that systemic inflammation is well controlled because even after doing surgery in these areas, there's a chance that the HS could recur at a hair follicle within or around that surgical site.
Mhm. What do some of the surgeries entail? You mentioned one more surface level one. What's happening when a patient receives surgery for this?
So there are different types of surgical modalities. Deroofing surgery, that's where you remove the top layer of these tunnels and remove the what we call gelatinous inflammatory tissue and allow for the wound to heal on its own. So we're leaving the wound open. We're not closing or suturing because we know that sometimes closing the wound actually increases the risk of recurrence in that area. Then you have wide excision, which is typically done by general plastic surgeons and some dermatologists too, where we're literally taking out the entire area that is involved and going deeper also with the surgery. And the wound healing, obviously, for that type of surgery takes much longer. So if we can avoid doing that type of surgery by doing deroofing surgeries early, that's best. But sometimes patients have more extensive disease.
Mm. What are some misconceptions that patients often have with disease manifestation or treatment that you find yourself addressing most often?
I would say a lot of it has to do with diet. We know that diet plays a big role in HS pathogenesis and the risk factors. So, talking about obesity, elevated BMI, metabolic disease such as diabetes, insulin resistance. We know that diet plays a role in all of those, and those are risk factors for HS. But I think a lot of patients don't understand is that diet alone is not going to fix or treat HS. It helps, but usually this needs to be done with in conjunction with treatment. So I have a lot of patients who believe that if they just change their diet and eat healthy, their HS will go away. But this is a misconception.
Does Do procedures such as, let's say, like laser hair removal or any of those other kind of, what some might consider cosmetic dermatologic procedures, do those play a role in kind of impacting the disease at all?
It's really unfortunate that laser hair removal is considered cosmetic treatment because for HS, it is not, and for a lot of diseases, it is not a cosmetic treatment. We know that hidradenitis suppurativa starts in the hair follicles. So, if we can decrease the amount of hair follicles that are present by removing them through laser hair removal, then we can decrease the risk of progression of the disease. We're trying our best the HS experts in our community, we're trying our best to put the awareness out there so that insurance companies can understand that this laser hair removal treatment is not cosmetic, but it's an uphill battle.
So is this something that you find that patients often resort to? Is this usually a first line of kind of treatment or something along those lines? Where does the laser hair removal conversation typically come in?
So for patients who have mild to moderate disease, that's something that I usually recommend, and it's also recommended in the treatment guidelines for HS. And we're having a hard time getting insurance coverage for these. So a lot of times, we're sending patients to medical spas that have these lasers and for the treatment. Yeah.
Mm. And I just want to just step to the wound care and the kind of post surgery recovery, because you mentioned not necessarily being able to suture things the way that you normally would. So, what does recovery look like with that type of surgery, typically for the
Yeah.
patient?
Well, it depends on the type of surgery that's being done. Is it deroofing or wide local excision? Wide local excision treats a larger area, so obviously that's going to take much longer to heal. But with the deroofing surgeries, we're looking at 2 to 3 months, where it completely heals on its own, and it's remarkable how quickly the body heals once you remove that inflammatory tissue. Yeah.
And then with the more intense surgeries, about what's the recovery time or process for patients?
Well, usually 3 months at least, or even more, given the extent of area that's treated. But patients are able to actually tolerate this because it remarkably, the post-op pain only lasts for the first couple of days or weeks after the procedure. So even though they have this open wound, the pain is actually minimal. I have a lot of patients who would tell me after they do the surgery that, wow, the pain from the surgery was not even as severe from the pain they get with their HS flares.
Wow. So, how do you manage recurrence after surgical intervention?
Yeah, that's a great question. So, you know, that tells us that there's still inflammation in the body, and we need to focus more on medical treatment before we look further into surgical treatment. So for those patients, if they are on a biologic medication and they're still getting recurrences, then we look at switching to other biologic treatments. Thankfully, now we have 3 biologic agents that are FDA approved. So it's a bit easier to get these treatments for these patients.
I just thought of this, thinking back to what you mentioned about laser hair removal. There are also topical creams that remove hair as well. Is this something that patients utilize at all, or is it what are the pros and cons of that?
Yeah, so we don't recommend those creams because they do have the potential to cause inflammation, so local irritation, but also these creams that's temporary removal. So these hair follicles will grow back eventually, and when they grow back, then that's when you start to get issues. Sometimes, especially in darker skin patients, because our hair follicles are more curly and coarse. So we are more likely to have ingrown hairs, and that can also cause HS to flare.
Mhm. Um, what other comorbidities, do you typically find? Are there kind of systemic comorbidities such like, diabetes, cardiovascular issues? Are there any of those, and how does that impact treatment, if at all?
There are a lot of comorbidities associated with HS. So we can actually divide it based on the organ systems. So thinking about endocrinology, so hormonal, diseases such as polycystic ovarian syndrome and diabetes, metabolic disease, and then thinking about cardiovascular. So patients with, are more likely to have hypertension and also cardiovascular disease. And then thinking about musculoskeletal, patients with HS also have a higher risk of inflammatory arthritis. And then gastrointestinal, patients with HS are more likely to have inflammatory bowel diseases like Crohn's disease and ulcerative colitis. So lots and lots of comorbidities associated with HS.
So, do you find that when patients control these comorbidities, does their HS then come under control? What is there a causal relationship?
No, there's no causal relationship, but we do know that the common denominator is that there's inflammation in the body that's driving these diseases. So a lot of times, what we find ourselves doing is actually a multidisciplinary approach where we work with other specialties to try to control the comorbidities because they're associated with higher mortality and higher morbidity in these patients. We also know that there are certain comorbidities, though, like diabetes, for instance, and insulin resistance. That if that's well controlled, then it is easier to manage the HS.
Mhm.
Yeah.
So how do you approach pain management for patients? Because it's pretty intense to think that the post-op pain is actually less than the actual HS pain. So I imagine they're in a lot of pain. So what's the pain management process for people with active flares?
So it's important to ask the patient what the nature of their pain is because pain can be divided into acute pain and chronic pain. And then not only that, pain could be depending on the nature of the pain, the symptoms, we can tell if the pain is more driven by inflammation or if it's more driven by nerve, irritation or nerve damage. And different pain medications target different causes of pain. So, for instance, if the pain is more throbbing, which we think is due to inflammation, then we focus more on medications that decrease inflammation, anti-inflammatory medications like, NSAIDs. And if the pain is more um, neural based or nociceptive, or, where there's irritation of the nerves, then we
Mhm.
focus more on medications that target nerve irritation.
Interesting. So, as far as medications go, I know that with things like sickle cell, for example, patients go into the emergency room and they sometimes have trouble getting their pain medication managed. Is this where are patients usually receiving their kind of pain treatment from? Are there some topical options for them, or is it always kind of a pill? How does that work? And does it come from dermatology, or does it come from primary care?
And honestly, all clinicians should be comfortable managing pain in HS. So not just it would be unfortunate for patients to wait to see a dermatologist, before their pain is managed. So, we encourage primary care, urgent care, emergency room facilities to manage patients' pain because a lot of these patients have acute pain with their flares.
Mhm. So, as far as patient age goes, you talked about this happening kind of typically after puberty. Is there a pediatric population for HS at all?
There is a pediatric population for sure, and as we know, the age of puberty is earlier and younger, right? So, but then those patients who have a family history of HS, so either mom or aunt or sister, those are the patients that are also more likely to have HS onset at an earlier age. So even patients as young as 10, 12 are getting these symptoms.
Is there any type of kind of intervention strategy when you know that someone has a family history of HS and they maybe have flare ups younger? Does the kind of process of treatment and addressing it does it prevent further flare ups in the future at all? What's the process with that?
So we're still learning more about this, but there actually was a recent study that showed that patients who were women who were started on oral contraceptives at an earlier age were less likely to have more severe HS disease. So that's one way to target this. So if you have a young patient who is getting flares and around their menstrual cycle, we could place them on an oral contraceptive to help manage those fluctuations in their hormones and potentially decrease or slow down the progression of the disease.
Mhm. And then how do you treat other special populations, for instance, with pregnant women where we know hormones are changing and flaring a lot, they're breastfeeding and things of that
Yeah.
nature? What complications and kind of factors come into play with treatment?
So yeah, so that's a special population. So we have to be careful which medications we use for patients who are pregnant and patients who are nursing, so as not to affect the fetus or or baby who's being nursed. So there's certain antibiotics and certain hormonal modulators that we cannot use during pregnancy. So we focus more on the tried and true antibiotics that are safe in pregnancy. We can do small local surgical deroofings if the obstetricians
Mhm.
are also on board. We work very closely with obstetricians when we're taking care of pregnant patients, and it's great that we have a database where we can see which medications are safe to use in pregnancy and lactation.
So, what is the long-term follow-up process for HS? Is there an ideal kind of stability range that people get to? Is there what's the ideal outcome for treatment?
So ideally, we want to decrease the progression of the disease. We want to manage the burden of symptoms. And we also want to decrease the amount of flares that patients get. So those are the three things that I look at when I'm starting a patient on treatment. And typically see patients back in 3 months because on average, that's how long it takes to see improvement, especially with immunomodulators and biologics. So every 3 months, I'm seeing patients until they're well controlled, and after that, we can space out the visits a little further. But it's important to continue to follow these patients, especially because of the high risk of comorbidities that they have.
Where do you see some of the gaps in the healthcare system as far as, it can be from diagnosis to treatment to maybe even research?
All three. So it takes on average 7 to 10 years for patients to get diagnosed. Um, Treatment wise, we still have a long way to go, but it's exciting. There's a lot of new and exciting research that's being done on targeted therapies. And then for research, again, it's very exciting. In the last decade, there's been an explosion of HS research and publications. But there's still a lot that we don't know about the disease, and we need to catch up with diseases like psoriasis that have a lot of FDA approved treatments. And for HS, we only have 3 FDA approved treatments.
And then what is the landscape of clinical trials, for example, and where do you think the gaps are with the clinical trials process? I know typically for even research in general, um, there's not a lot of data on certain populations. Like there's not a lot of data for Black people in general. So how does that impact just the clinical trial process? Where are the gaps in the data?
So we know that clinical trials lack representation. of minority, groups. And it is something that I believe the pharmaceutical companies are working hard to correct. So for instance, at the University of Chicago, being located in the South Side, I tend to see a lot of Black patients, and I've approached the pharmaceutical companies as to why these clinical trials were not conducted at places like University of Chicago, and so that's changing. So hopefully, we should be seeing more clinical trials in the future.
What would you say to your fellow doctors, maybe whether they're primary care or dermatologists? What do you think is kind of missing in the conversation, or what would you like to see more of when it comes to patient care and things like that?
I would say we need to start talking more about the psychosocial issues that patients with HS face. There's a huge burden of the disease that affects all facets of their lives. I mean, patients with HS are more likely to come from a lower socioeconomic status. They're more likely to be unemployed, have difficulty keeping a job. They're more likely to also have issues with their personal relationships. I mean, if you think about how embarrassing this disease is to have lesions that are leaking, foul smelling, that's going to also impact your personal relationships. So these patients have a higher risk of depression, anxiety, illicit drug use, and sexual dysfunction.
Interesting. And, I what are some of the things that patients do to self-medicate? Because my brain is now going to cannabis use, for example, and things like that that are typically used for pain management. But at the same time, smoking is might, cause the problem even more. Are you finding, with the legalization of things like cannabis, that patients are turning to those types of treatments, and how is that impacting care?
That's a great question. Patients are desperate and they're going to find whatever they can find to help with the pain. And I welcome research looking at the use of cannabis to treat pain, but we know that smoking it may not be the best option because for some reason smoking is linked to inflammation in the body. So but we need more data. We need more research. Are there ways that we can that the cannabis or the treatment can be delivered safely so that it doesn't increase or induce inflammation? Patients are also, using home remedies that may not necessarily be good for their skin and sometimes can also increase inflammation. And then patients are also, you know, turning to illicit drug use or alcohol, which does drive inflammation too.
What are you looking forward to in the field? It can be in any aspect, research, care, patient outcomes.
I'm looking forward to more and more primary care and urgent care facilities being um, comfortable managing mild to moderate disease. If we can manage these patients early, we can slow down the progression of the disease and we can decrease the amount of patients that are have severe disease. So I'm looking forward to that. I'm looking forward to more medications that are FDA approved for treatment. I'm looking forward to personalized care. There are different phenotypes of HS. There are some patients who have HS and it's linked to obesity, and there's some patients that have HS and they can't even gain weight. So those patients obviously have different types of HS, and we need to treat those patients differently. So one treatment may not be the best treatment for another patient who has a different phenotype.
Well, thank you so much for joining us on MD Newsline. It's been an absolute pleasure.